Welcome everyone to today's ED Stop Suicide QI Collaborative Fireside Chat on Discharge and Safety Planning. We are, of course, so very grateful to our HRSA colleagues who support not only the EMS for Children Innovation and Improvement Center, this collaborative, but also today's event. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. These are the topics that we're planning on talking about today. Just a few reminders. We're so very grateful to you for taking time today for joining. You will be on mute for the entire presentation. This fireside chat, like all others, is being recorded, and the recording as well as the slides will be posted online for you to access later. I want to call your attention to the Q&A feature down below. Please feel free to put any questions you have along the way in that Q&A box, and we will either answer them right away, or if time permits, we will answer them at the end of the presentation. Nursing professionals, social workers, and other mental health care providers, please put your first and last names in the chat to make sure that you get your continuing education or contact credits. So definitely names in the chat, questions in the Q&A feature, and then please do stay until the end, because not only is there a very brief session evaluation poll, but there will be a QR code or links that we will put into the chat for those of you who need the nursing credits or the social work or other professional hours. I would like to turn this over. Well, no, not yet, actually. These are the objectives for today's talk. You can read them on the screen. And now I'm going to turn this over to my colleague and friend, Sheryl Yanger, to introduce Neil. I'm not going to say anything much about this particular slide. There's a lot of information on it. It will be available to you in the slide presentation that gets posted online. And again, at the end, you'll see the chat will show the code and the link for you to seek your credit. Thank you.
Thanks, Laura. So it is our pleasure to introduce Dr. Neil Uspal today. We're so lucky to have him come talk to us. He's an associate professor in the Department of Pediatrics at the University of Washington and an ED physician at Seattle Children's Hospital. He's the ED liaison to the University of Washington Department of Psychiatry and is a member of the Seattle Children's ED Mental Health Committee, an ED Mental Health Leadership Collaborative, through which he's engaged in multiple QI initiatives around mental health care. His primary academic interests in mental health include means restriction, specifically around firearms and process improvement. And he's also a member of the Seattle Children's Hospital team participating in the Stop Suicide Collaborative. So he is going to talk to us today. Christina, we can go to the next slide. We're going to talk, this is going to be related to our intervention bundle guide 4 regarding discharge and safety planning. And you can read the global aim here. And then on the next slide, it goes over our quality measures that will be included in bundle 4 and will be on the bundle guide that we will post to the website soon. And I'll leave it to Dr. Uspal now.
Great. Well, thanks for having me. Really excited to be part of this collaborative, really excited to present today, and excited to follow up all the other great speakers we've had as part of these fireside chats. I will do my best to match their high quality talk. We go to the next slide. So my goal, a couple goals in putting this talk together today and just thinking about the audience and thinking about the collaborative in general. I think the first part of this talk is just going to sort of recall out just how high risk our patients are with mental health complaints who we're discharging from the emergency department. Really just help us focus on sort of what the stakes are when we take care of these kids. And then as we go through sort of benchmarks and different practices around discharge planning and means restriction, really I want to try to call out potential targets for quality improvement. I know a lot of you work in disparate settings, some in children's hospitals, some in community hospitals. I know everybody's already doing a lot of this work and providing great care, and so some of this may be a little bit repetitive, but my hope is this will inspire some ideas for change or things you can target as potential QI interventions. Okay, next slide. All right, so I'm an ER doc, as Dr. Yanger said. And so we always start talks with a case. And so I'm going to start with a case in this talk as well. So this wasn't too hard. I was putting these slides together, and this is actually a girl I had seen the day before I had put this slideshow together. So I think that just speaks to how frequently we see these kids, just how much of an issue is taking care of these patients and their families. So this particular girl was a 16-year-old with a known history of depression. She was fairly well connected. She saw a therapist. She was on sertraline prescribed by her PCP. She came into our emergency department with EMS after an intentional ingestion of cold medicine. And this wasn't recreational. This was a suicide attempt. So they brought the bottle. The bottle was completely empty. She said she drank the whole bottle. We sort of did the math and what was in there, and the bottle had about 5 grams of acetaminophen, about 160 milligrams of dextromethorphan, and about 3 grams of guanfacine. If you do the math, that acetaminophen is a little bit below the toxic level. It's sort of close, but below generally the concerning threshold, fortunately. When we talked to her, she was awake, able to answer our questions, but was fairly tearful with a flat affect. Had a pretty normal exam. Her family was at the bedside. Not sure if they came with the ambulance or came separately, but they were there by the time I saw her. Next slide. So we, usual care, we decided, just because we weren't totally sure how much acetaminophen she took, we did get a 4-hour acetaminophen level, and it was below the toxic threshold where she would need admission or treatment. We talked to our poison control colleagues, and they told us, with the dextromethorphan, they recommended watching her for 6 hours, making sure she didn't have any side effects or complications. So she stayed in our emergency department. We checked her on at the end of the observation period. She was still doing well. And so we deemed her okay for our mental health team to evaluate her. By that time, the patient was upset about what had happened. She was denying current suicidality. And the mental health team came to us and said they felt like she didn't need inpatient psychiatric admission and we could send her home. And so next slide, or next click. And so, this kid went from, 8 hours ago, she was taking an intentional ingestion with the goal of self-harm, trying to kill, complete suicide. And now we're like sending her home, back to the community, back out in the emergency, back out in the community. And so the question is, what can we do in the next day, the next week, the next month? What can we do in our emergency departments to minimize this patient's risk, that she won't come back with another self-harm attempt, that she won't come back engaging in a more lethal means of attempted suicide? Next slide. And just some background numbers on the patients we see in the emergency department. So about 40% of kids who present to the ED with a psychiatric complaint don't have a standing psychiatric diagnosis. So these are kids we know, kids are underserved in the community. There's a lot of kids out there who have psychiatric issues who do not receive psychiatric care, and many of those kids end up in our emergency departments. More than half aren't cared for by a psychiatrist. I know in our center, and probably many of yours, we see a lot of sick, sort of very high level, very concerning mental health complaints. And the reality is most of these kids we end up sending home. About nationally, 75 to 80% of patients seen in emergency departments for a psychiatric condition are discharged home from the emergency department. So as sort of high level and severe some of our psychiatric cases are, we don't have capacity to admit these kids in many cases. There's some question even how useful psychiatric admission really is in many cases. So the reality is we're sending many of these kids home that we're taking care of. And we know kids, there's variable follow-up post-ED discharge. Dr. Hoffman, who did a Fireside chat a couple of weeks ago, published a study this year that showed only 31% of children with Medicaid had an outpatient mental health visit within 7 days of their ED visit, and only 56% of kids had an outpatient mental health visit within 30 days of their ER visit. And we know, unfortunately, that follow-up rates are much lower in minoritized populations. They're much lower in rural populations. Poor access to care in both situations. And so, sort of in summary, there's a lot of kids who aren't getting mental health care before they get to the emergency department. We're sending kids home from the emergency department, and a lot of those kids aren't getting care when they leave the emergency department. And so that really calls out how important it is that we set these kids up for success while they're in the emergency department. Next slide. And just once again to call out how high risk our patients are. There's been a number of studies in both adults and kids on this topic. Probably the best one was a meta-analysis published in JAMA Psychiatry a few years ago. And that study looked at kids who were admitted to psychiatric units. And they found basically all comers, if you were admitted to a psychiatric unit, your annual rate of completed suicide subsequent to admission was about 0.16% per year. So, think of all the kids we admit to psychiatric units. More than one, a little less than 1 in 500 of those are going to complete suicide per year. Super high risk. And when you compare that to our asthmatic patients, when you compare that to neonates with fever, these kids who we spend a lot of times worrying about their medical complaints, I think that just sort of focuses how high risk and how much time we should spend helping to take care of these kids. When you look at kids strictly who come to the emergency department, there's a couple studies that have basically show that the long-term risk of suicide in adolescents who present to the emergency department for self-harm visits is about 0.6 to 0.7%. So once again, less than 1 in 200 of the kids we see who engage in self-harm before they come to the emergency department are a high likelihood for completing suicide. And those numbers are a little less for those who come to suicide with suicidal ideation. It's probably about 0.3%. So really, once again, really, really high risk. So, I sort of have to check myself in the emergency department too. You're running around taking care of a lot of kids. Oh, here's another mental health patient. But really focus on how high risk and how important it is that we provide quality care for these kids. Next slide. So, to summarize why we should intervene in the emergency department when we have these kids. Once again, a lot of these kids we lose to follow-up. This is our window. The emergency department is our window to help these kids and provide high quality care. They may or may not obtain care when they leave our emergency department. And certainly we can, as I'll talk about in a little bit, help them sort of get care through our processes in the ED. Once again, these kids are at high risk for suicide, as I just talked about. So high risk of mortality, sort of requiring action. And then beyond that, I think, when you put yourself in the shoe of these patients and families who come in, they come to our emergency department in crisis. We know from our data at Seattle Children's, most families who come to the emergency department for a mental health complaint expect to be admitted. These families sit certainly at our institution, they sit waiting to be seen by a mental health professional for 4, 6, 8 hours. And then we know most of these kids from the stats, both at our center and nationally, end up going home from the emergency department. At our center, we don't adjust medication. So these families come in crisis, they spend 8, 10 hours, 12 hours, maybe they board in our settings. And then we say, okay, it's time to go home. And so really intervening and providing counseling for these families really adds value. And, I've seen it both ways, and definitely, I think these families appreciate the fact that we sort of help them succeed once they leave the emergency department. And finally, if that's not enough reason for us to sort of look at our practices, the Joint Commission in 2019 put out new elements of performance around caring for patients with suicidality. And one of those elements of performance is that hospitals are required, and you can see it on the second line, this is pulled from the Joint Commission statement, but hospitals are required to follow written policies and procedures for counseling and follow-up care at discharge for patients identified at risk for suicide. So essentially, this is a mandate from the Joint Commission. So as you look at your processes and decide how you want to improve things, if you get pushback from your leadership regarding resources and the time to do this, I think it's fair to call out, hey, the Joint Commission is telling us we have to do this. So supports what we're doing. Okay, next slide. Okay, so I want to shift gears a little bit to talk about interventions we can do while patients are in the emergency department before they leave. And there's a number of interventions in the literature. I'm going to focus on the safety planning intervention during this talk. And there's a number of reasons for that. Number one, this is probably one of the better studied interventions out in the literature, and I'll sort of talk about the evidence behind it. Number two, this is the intervention that the Joint Commission talks about when discussing elements of performance and care of patients with suicidality. And number three, this is the safety plan intervention is really designed to be a short intervention designed specifically for the emergency department. It only takes about 25 to 40 minutes. And it's something that actually, was actually initially designed for adolescents. It was probably better studied in the adult patient population, but can also be used in adolescents and even kids who are younger, as we'll talk about. So the SPI was designed by two psychologists, Barbara Stanley and Gregory Brown. It's talked about it single session, and it's really focused, we'll talk about this in the next slide, but focused on the management of the acute suicidal crisis. So we're not sort of fixing people's depression or sort of adjusting medications. We're looking at what brought them to the emergency department and finding ways to ameliorate and reduce risk of that crisis recurring again. It intervenes in multiple domains, so it includes means restriction counseling. It includes sort of crisis aversion. So I think even though it's short, it looks at multiple things we want to do. And there's really good evidence for efficacy in adults in emergency departments and also in kids outside of the emergency department. And I should note that a lot of these interventions, whether it's SPI or some of the other interventions out there, they all sort of have the same focus on the same thing. So whether you use SPI at your setting or use something else or maybe adapt a different process, I think the core concepts of these interventions are all fairly similar. Okay, next slide. So this is probably the best study of SPI, which was published in JAMA Psychiatry a few years ago. And it was done in the adult community. It's a multi-center study done at VA hospitals where they compared usual care to SPI plus 2 follow-up calls, called SPI plus. And we'll talk about follow-up calls a little bit later in this talk. But they found that the patients who received the SPI plus intervention had a subsequent decreased risk of suicidal behaviors versus those who just got usual care. And it's a fairly significant change, as you can see from the numbers. And they also found that there was an increase in attendance in outpatient follow-up. And so, any intervention that can show actual change in behaviors, is a pretty significant finding. Like I said, the evidence isn't so robust yet in pediatric patients, at least in emergency departments, but hopefully we're going to get there soon. Okay, next slide. Okay, and once again, as I mentioned earlier, SPI is really focused on the emergent crisis. This slide is actually, I pulled it from the Joint Commission to sort of illustrate how the emergent crisis happens. So most people are sort of bobbing along at baseline and, maybe they have depression, maybe, things may or may not be so great, but then something happens, there's a trigger. So in this slide, for example, at work, and this is an adult example, but a supervisor was critical of the patient. And so that patient engages in sort of negative, sort of a warning sign, so it's getting escalated, so negative thoughts. And then this person engages in what I would, maybe not everybody, but I would say is maybe a negative coping strategy where the person's drinking beer. And then sort of they become more escalated and they sort of engage in externalizing behaviors, arguing with their wife. And then the negative self-talk increases until they reach the moment of the crisis. That moment of crisis is actually very, very short. The period where people are suicidal is actually very, very short. And in this case, something abruptly interrupts that sort of moment of crisis. Once that interruption happens, the person de-escalates. They actually regret their desire to complete suicide, and then they seek care. And certainly in our settings too, of the mental health patients I see, you know, a lot of them, by the time they even get to me, are sort of regretful of what happened and wish they didn't do it and things like that. So once again, so that's the model, and the goal of SBI Plus is to step in before you reach the suicidal crisis and give people skills to sort of avoid that. Next slide. This is the model we use at our institution. This is sort of what we talk about with patients and families, and it's very, very similar. I did a little like asking around, like, you built this off SPI, right? And nobody could really tell me that. So I'm not sure if we internally developed this or pulled this from SPI, but our framework is very, very similar. So once again, you know, somebody's at baseline, you know, maybe they're dealing with depression, other issues, and then there's some trigger, you know, maybe break up with a significant other, maybe argument with mom, maybe something on social media they saw that sort of triggered them. They escalate, reach crisis, and then de-escalate, and then come and seek care with us. And so we have an opportunity, we're at the baseline problem solving area where we can actually really work with patients and families to sort of avoid these escalations again. Next slide. So this is actually an image, I pulled this straight from Dr. Stanley and Brown's website. This is essentially the SPI safety plan. As you can see it, they sort of cram it into one page. There's not a lot there. They say it takes about 20, 35 minutes. I think maybe a little bit more with pediatric patients, but this is doable in an emergency department setting. Okay, next slide. This slide is actually from the Child Mind Institute. Once again, I just looked for this online. This is a free resource they had, and this is essentially an adaptation of the SPI for adolescent patients. So these resources at least are available online. Next slide. When you think about intervent, now while these resources are available online, you do want to implement these in sort of a thoughtful way and support your staff when you do so. As I said, there's not only the SPIs online, there's free online trainings. For example, the Zero Suicide website has a link to SPI training from New York State, which is free and readily accessible. Found a couple of other SPI training resources as well. In general, Dr. Stanley and Brown recommend about a 1-hour training for staff who are implementing this in clinical settings. And you do want to provide your staff feedback. So there should be an initial observation period if you're implementing this. You know, whether it's someone, you get somebody from the outside that sort of teaches content, or you have, you know, somebody, a psychologist or psychiatrist. You do want to sort of allow people an initial observation period and give people feedback. So you just don't want to print out this paper and say, all right, now do crisis plan it. And the reason for that, you know, everything looks good on paper, but, you know, as we all know, a lot of our patients and families can present challenging challenges as we sort of provide crisis planning. You know, we treat kids with developmental delay, you know, patients with aggression with concomitant suicidality, and certainly we deal with variable family dynamics in the patients and families we work with. So, you know, getting that experience before sort of formally doing this on your own, I think is critical. All right, next slide. So I did want to briefly walk through the SPI. This certainly is not a substitute for training in SPI. And full disclosure, as a emergency room doctor at our center, we have mental health staff who actually does this on a day-to-day basis with families. So I'm not the one doing this every day, but I still think it's helpful to sort of think about the strategies that are in SPI and just have an understanding of the concepts behind it. So the first part of SPI is sort of talking with patients about what are their triggers for suicidality. And certainly in our setting, you know, we work with a lot of kids, you know, many of them will say things that are pretty general, like, you know, my mom is the trigger. Okay, well, I understand your mom, you know, your mom is somewhat triggering, but what does your mom do that is actually triggering? It's not a person who is triggering, there's a specific action or thing that happens. So you really want to focus on the actual specific things and details of the things that people find triggering. And, you know, with kids, oftentimes what we'll do is sort of do this initially with the patient by themselves, and then depending on the situation, pull their parent in and sort of collaborate through the safety plan. And then move on to warning signs. Okay, so when you're triggered, when you know you're sort of escalating, how do you know? What do you feel? And in some patients, it'll be more internal, so they'll feel their heart rate going fast. Maybe like in the example earlier, it'll be negative thoughts or sort of thought processes where sort of negative self-talk. Or some kids who may externalize. Maybe they'll become aggressive towards family members. Maybe they'll be destructive of property, things like that. So helping the patient both recognize their triggers and their warning signs allows the person to say, hey, I'm entering into crisis. I can do something to sort of avert this crisis. And then you move on to coping strategies. Okay, so now we recognize you're escalating and getting into crisis. What can we do to sort of avoid escalating further? And what we do at our center at Seattle Children's is sort of first focus on, okay, what do you do right now for your crisis? What do you do right now in your crisis? Acknowledging that, you know, no matter what people do, there's some function to it and does something positive for them. Now, it may have negative consequences as well, and we sort of talk through that. But, you know, for example, you know, a lot of patients engage in cutting behaviors. And we recognize, you know, as much as we sort of, as providers, that we don't want you to do that, you know, we need to recognize that, you know, that cutting behavior distracts the person from thinking about what's triggering them, thinking about their suicidal thoughts. So it does have a positive, does something positive for the patient. But once again, we want to move away from sort of more negative, help people, number one, recognize sort of what may be negative about some of those coping strategies, and then help them more generate positive, more functional strategies. So whether it's, you know, taking deep breaths or thinking about something, you know, somebody they care about, or thinking about reasons to live, things like that. There's another intervention called the FISP, which I'll briefly mention later, that sort of actually has people put things in like a box. And so when they're in crisis, they can open that box and think of positive things. So any sort of coping strategy people can come up with to sort of get out of crisis. Next slide. This is another tool we use at Seattle Children's, going through this COPE mnemonic with people. So, okay, so once you recognize you're entering, sort of getting escalated, take some deep breaths, sort of try to calm yourself a little bit, and then sort of rationally what are my best options? What can I do to help myself cope? And then the P is like picking out one of those options. And then the person sort of goes through that, and then after their coping strategy, evaluates how the option works. So many times it maybe doesn't work, maybe they're more escalated. And so then they move on to another coping strategy. We give kids in our emergency department, and I'll show a picture of this in a couple slides, but trigger cards, where it sort of lists all the coping. We have people actually write out all their coping strategies and write out things that are positive. And so it's a visual cue for somebody who, I feel like I'm escalating. What can I do? Let me look at this card. And once again, we emphasize with people, and it's important to know, we're not fixing the underlying problem, we're helping you get through the emergent crisis. Next slide. Then we sort of move on. If sort of your internal coping strategies aren't working, what are some healthy activities you can do to distract you from your suicidal thoughts or suicidal ideation? And in general, as you're encouraging people to come up with this list of things to do, you want to encourage people to do what we call opposite to emotion action. So somebody who is withdrawing and sort of internalizing and has sort of internalizing negative thoughts, you want to encourage them to do something more active. So maybe going for a walk, or maybe doing something more social. Somebody who sort of becomes escalated when they're in crisis, you want to encourage them to do something that's maybe calming. You do want to help people identify things that are both healthy and adaptive. You know, one example that comes up is, you know, maybe going and taking something out in the backyard and breaking it helps you and distracts you, but probably not so adaptive. Not gonna, you know, what are your other family members going to think about while you're doing that? So helping people come up with strategies that work in their family setting. And once again, you know, when, you know, especially, you know, we have the benefit of having caregivers involved in this process too. They can help people identify both sort of how, when they escalate, what do they do? For example, a parent might say, hey, I see when you're clenching your fist, I know you're sort of starting to escalate. And then caregivers can support people, you know, also provide support and strategies to help with distraction as well. So if that sort of the person self-engaging in distracting activity doesn't work, sort of the next step as part of SPI is identifying social supports for the patient. So who are people you can reach out to support you and provide you help? In adolescents, in our pediatric patients, we emphasize it's not the caregiver. Hopefully the caregiver is already engaged. So who are people who are a little bit outside the home and outside your immediate family who can help you? We try to have people identify a range of people, maybe somebody at school, maybe a therapist, maybe a another family member. And especially in the adolescent population, you want to make sure these people are agreeable to both the patient and the caregiver who's with the family, is presenting with the patient. You know, the patient may identify a friend who may or may not be a bad influence, or maybe the parent perceives that person as a bad influence, so that may not be the ideal person to be a social support. And then once again, okay, if you're escalated where now you're to the point you need professional help, who are the people, who are the resources you reach out to get you immediate help? And you do want to give a range, a spectrum. So maybe it's your outpatient provider, and certainly you want to include crisis lines, 988, and potentially 911 as well. So if you're in immediate crisis and you need immediate help, and we give the person the actual crisis plan. Okay, so if you were in acute crisis, call 911. Great, and I'll try. I'm just looking at the chat. I will try at some point to put the link for the safety plan. I think it's actually in the slides too, but I'll try to find it. And then finally, I'm going to touch on this, spend a lot more time on this at the end of the talk, but SPI also involves means restriction counseling. So an element of going through basically removing potential means of suicide from the patient's access. And certainly in pediatrics, that's sort of 2 steps. You want to talk to the patient about that, but you really want to pull the parent out and do means restriction counseling as well. The parent may not perceive the kid knows about the firearm, the kid probably does, but certainly want to talk about things away from the patient, so they may or may not know what means of suicide may be in the home. Okay, next slide. Okay, so here's just an image of we used to call it a coping card or a trigger card, use the old language. We've actually now switched it to a coping card. That's probably better language. But this is once again very, it's not explicitly based on SPI, but the concepts are very, very similar. So once again, what are your triggers? What sets you off into crisis? What are your warning signs? And then providing coping mechanisms. Okay, what's things you can think about that make you grateful or make you feel safe? Next slide. And this is the back of the card. What are my strengths? And then what are your coping skills you're doing now? And let's hear some new coping skills you can try. Next slide. And this is actually an image from a paper that was just published this year, basically, which is describing the CSPI, which is an adaptation of SPI for children. And so the CSPI is designed for kids as young as 6. And so these same concepts can be used in young patients. Now, this CSPI has sort of more language that is appropriate to kids and uses pictures and things like that, but the concepts are pretty applicable across the age spectrum. Okay, next slide. All right, so that's sort of a very brief overview of SPI. And I think, once again, Joint Commission sort of mandates counseling for patients who present with suicidality. So I think that's a great short intervention you can do with patients and families. I want to move on a little bit to talk about follow-up. As I alluded to earlier, follow-up is highly variable. In some studies, follow-up rates are as low in the 30%. I've seen studies where the follow-up rates are as high as 80%. And I think a lot of that depends on the population you're working with. We know there's lower rates of follow-up in Medicaid patients who are minoritized, and in rural populations. So as you're thinking about your QI interventions and sort of looking at your care processes, I really think it's important to look at how we're taking care of these kids, not just in follow-up, but across the board with an equity lens, and acknowledge that, hey, the kids who need intervention, the kids who, these kids in vulnerable at-risk populations really need us to support them in getting care after they leave our emergency department. So I think it's incumbent on us to make sure kids get care when they leave ED. We know that the period after being seen in the emergency department is the highest risk. Really, within 30 days of ED visit is the highest period of risk, and there's certainly high risk in the months after ED visit. And so really, a psych appointment in 3 months is not acceptable, because that kid isn't, the highest risk is well before that. So as we set up, giving somebody a phone number and saying best of luck, I think that's important, and you want to give people resources, but I think we have to look critically at the resources we are providing families, and do those resources we are providing meet people's needs? The good news is there's pretty good literature, at least for kids who are hospitalized, that a mental health visit within 7 days of hospitalization does decrease suicide risk. Now, it's a little different population, kids in the hospital versus kids were discharging from the emergency department, but I think there is evidence that if we make the effort to follow up with patients and families, we can actually reduce their risk. Next slide. So once again, as you look at your processes and look at QI targets, think about what your existing community resources are, what is access to care in your community, and then think about, and many of you may already be working with these groups, but think about the crisis stabilization services you have in your community. And these are a great resource, and there are more and more of these coming online, as I'll sort of discuss. So this is a really good area to sort of think about your care processes. So these services, as many of you know, are primarily run by local governments. A lot of them are actually run and coordinated by the state government, and they tend to be funded either by local, state, or federal money. Some have foundational funding as well. And these crisis stabilization services can meet families in the community oftentimes after ED discharge. So certainly at our institution, we will arrange for patients who don't have follow-up care, and we think it's appropriate. We'll arrange for these crisis services to come out to their home as soon as the day after their emergency department visit. Crisis services both offer sort of help on the front end, so families can call these crisis services when they're in crisis and get somebody to come out, usually 24/7, and then they offer continued assessment, so they can be a great link between ourselves in the emergency department and ongoing outpatient care, sort of bridging. Now, I think the general consensus is dedicated pediatric teams are more beneficial to patients and families than sort of crisis teams that are across the board for both adults and kids. It's variable whether communities have dedicated pediatric teams. Certainly, I think it's something that we should all advocate for as these sort of become more and more online. And just to call out, certainly true in Washington State, the availability of these crisis services are variable across communities. Go ahead, next slide. So in Washington, where I work, these crisis services are, provision of these services are delegated to the county at the county level. So in King County, where Seattle is, for all the problems with our mental health system, we actually do have a fairly robust crisis outreach service. And so they're available 24/7, and we can coordinate with them to follow up with patients in the outpatient community. We know, though, as we have kids who come into our center from other counties, their crisis services are oftentimes much more limited. So we sort of have to work around that. So depending where you are, you may not have these full crisis services. Next slide. So this is just wanted to highlight a couple other states. This is from Connecticut. They have statewide mobile crisis intervention services. Once again, these are dedicated to kids. This is pediatric specific, and 24/7, and they'll come out and can coordinate with these groups after ED discharge. One more slide. And I didn't want to just focus on blue states, so I also pulled out, this is a great program in the state of Oklahoma. Many states, across the board, there's some variability, but there's a lot of red states that have great programs too. So in Oklahoma, for example, they have a statewide program, statewide 24/7 availability. So you call this helpline and you get a statewide coordinator, and they'll dispatch a local crisis response team, and they have a dedicated pediatric teams. Once again, available 24/7, potentially help with discharge care, and they triage based on the severity of the crisis call. Okay, next slide. And the good news in this area is more and more of these crisis services are coming online. This is basically information about funding from the ARP, the American Rescue Plan. This is like the Biden administration post-COVID economic stimulus plan. And so within that plan was money for these services. And so you can see at the bottom of the slide, they funded mobile crisis intervention services in 20 states. The list is at the bottom. So hopefully more and more of these crisis services are coming online, more and more communities. And so I think it's helpful to reevaluate, maybe if you didn't have access to these before, reevaluate maybe, these services are coming online soon. Maybe we can do something to better help with crisis care post-ED discharge. Okay, next slide. I do also want to call out as a potential QI target, engaging in follow-up phone calls. When you look at sort of the interventions in the literature for kids in the emergency department, almost all of them include some element of phone follow-up after ED discharge. So SBI Plus included, the plus was a phone call within 72 hours of ED visit. That was just a sort of repeat risk assessment, potential revision of the SBI if needed, and then helping facilitate outpatient treatment. FISP, which is another great adolescent intervention that's been studied pretty well in the literature, includes a phone call at 48 hours and then as needed. So, and that phone call served for both care coordination purposes and sort of motivating families to seek care. You know, these kids come in, their families come in, they're at the height of crisis, and then we send them home and the crisis is over, and it's very easy to sort of go back to what you're doing. We all have stresses in our lives and sort of forget about that immediate crisis you had. And so I think that follow-up phone call sort of helps refocus people. All right, wait, this is not a crisis that ended. This is something that we need to continue to engage in. Okay, next slide. This is a study conducted by Dr. Grupp Phelan, who did one of the other Fireside chats. And this was looking at kids who screened positive for SI. They were coming in for another complaint and had a mental health screening. They screened positive for SI. And so they randomized kids in the study to either what they called enhanced usual care, a brief evaluation and a referral to care, or they said the STAT ED intervention, which included a brief motivational interview, a discussion of barriers to outpatient care, referral, and then follow-up phone calls that included a case management piece. And so in the study, they found no statistical difference at 2 months follow-up. Although, you know, if you actually look at the numbers, that's a 50% increase in outpatient mental health care engagement. So I would say that's clinically significant, if not statistically significant. And then they found increased follow-up, both clinically and statistically significant at 6 months. So that wasn't a primary outcome of the study, but they did see a clinically significant increase in follow-up at 6 months. So once again, just driving the home that if you can do it, and everybody's, you know, resources are different in their care settings, and everybody's volumes are different, but just something to think about. I think follow-up phone calls, if you have the resource, it sort of doesn't take a ton of time, and it can be really beneficial to help families engage in follow-up care. Okay, next slide. It's slowly coming through. So I'm going to shift gears, and sort of for the last portion of my talk, I want to talk about means restriction. Means restriction is defined as reducing access to the lethal means of suicide. And for this talk, we're going to talk about means restriction on the individual level. You can also talk about means restriction on societal level. You know that safety cap on the Tylenol is a means restriction on the societal level. Blister packs. Iron was a huge, you got these big bottles of iron, and people would overdose in iron, and they started putting the iron in the blister packs, and they were harder to open. I think that's regulations actually slipped on that, unfortunately. Even putting a fence on a bridge is an example of means restriction on the societal level. But really, for this talk, we're going to focus on individual means restriction, specifically focusing on physically impeding access to the means of suicide in our patients. Next slide. And there's a bunch of domains in which it's important to engage in means restriction. Certainly talking about access to medications. Sharp objects, knives should be locked up. Ligatures or ropes are actually a fairly big risk, maybe bigger than we give credit for. So discussing with families, reducing access to ropes and ligatures. But for the purposes of this talk and the time we have together, I really want to focus on firearms, just because sometimes it's difficult to provide counseling on firearms, and they're so high risk that I think it's really important as we engage in care, patients and families, and look at potential QI targets. I think it's something that's worth potentially focusing on. Next slide. So adolescents don't often attempt suicide with a firearm, but if they do, it is a highly lethal means of suicide. And this comes out in the numbers. When you look at means of completed suicide in adolescents, a little less than half of completed suicides are by firearm in the year 2020, and that's pretty consistent. A suicide attempt by firearm is over 90% lethal versus 2% lethality of overdoses. And so when you're thinking about your individual patient and how you counsel them, how much, if somebody overdoses on they find pills in the cabinet and they overdose, chances are that patient is going to survive that overdose attempt. If they find an unlocked gun in the closet and they attempt suicide, chances are the patient's going to complete suicide. So this is, you think about how you counsel patients and families. balancing what do you spend more time talking about, and both are important. I don't want to minimize talking about medications as well, but just knowing sort of the relative risks of the various means of attempted suicide. We also do know pretty well from the literature that there's a definite relationship between exposure to firearms and increased risk of completed suicide. So in one study, adolescent suicide victims were more likely than controls to have a firearm in the home. And then in another study, comparing adolescent suicide victims to those who attempted but did not complete suicide, those who completed suicide were more likely to have a firearm in the home that was loaded, unlocked, and with the ammunition unlocked and stored the firearm than those who did not complete suicide. So we know having a firearm in the home increases your risk of suicide, but we know safely securing that firearm can at least somewhat decrease that risk. So as we talk about means restriction, keep that in mind. Okay, next slide. So here's a picture of a lockbox. Some are keyed, some are combination. This is a super simple 3-number lockbox. I could probably spend maybe I overestimate my abilities, but I feel like I could probably spend 10 minutes and get this thing open. Similarly, I could, so it's a keyed lockbox. I could, find somebody's keychain, pull that key off, and I would have access. So these things aren't that complex, but they do benefit. So the question is, how do these simple barriers reduce the suicide risk? Next slide. And so as I alluded to earlier in talking about SPI, suicide, once again, is extremely impulsive and the suicidal period is very short. In adults who attempt suicide or attempted suicide, about half of them went from deciding they were going to attempt suicide to actually committing the action of attempting suicide in less than 10 minutes. This is true in the adolescent community as well. It's pretty good literature that in adolescents who complete suicide, about 1/3 of them experience the trigger or the crisis which prompted their suicide attempt within 24 hours of the actual attempt. So this is not something people have been planning for hours or days, for days or weeks. This is something that there's a trigger and there's an impulsive decision. I'm going to attempt suicide and then find the means. How am I going to do it? And if there's lethal means, that's high risk. If there's no lethal means, it's much lower risk. Talking with undergrads too, in undergrads who experience intense suicidality, about half of them, their period of intense suicidality lasted less than a day. And then in about 31%, it lasted less than an hour. And so you can imagine that undergrad, there's a loaded firearm around them in that hour, much higher risk than somebody where that firearm's not available. Okay, next slide. So this is a figure I either adapted or stole from this paper by, it got cut off there, but Carol Barber. So if you have a suicidal adolescent, I'm not clicking, so it's going through it. If you have a suicidal adolescent, if they have access to a firearm, that's obviously a really bad situation. If you remove access to that firearm, either by locking it up or removing it from the home, there's sort of two different strategies the adolescent might take. So maybe they'll say, I'm not going to use that firearm. I'm going to use a substitute means. So there's a big bottle of pills over there. I'm going to use those pills. I know where the knives are locked up. I'm going to take a knife and try to harm myself. We know all those means of suicide are much less lethal. And so a person engages in a non-lethal attempt. They immediately regret it. They come to seek care, and we get them through the crisis. We provide medical care and then provide psychiatric care for them. Or maybe the youth is like, I really want to try with a firearm. There's a delay, but I'm going to get a firearm and attempt suicide. I'm either going to figure out this lock or I'm going to go to my friend's house and get a firearm there. That delay in and of itself allows the crisis to abate. Once again, maybe the crisis resolves and the person doesn't attempt suicide. So once again, if you can sort of, even for a short bit, reduce access to that firearm, it reduces risk. Next slide. So the first piece of counseling people on their firearms is actually identifying there's a firearm in the home. And in general, the literature shows we're not that great about doing this. There's a couple studies I've seen where rates of identification of firearm ownership in families of kids presenting with suicide is as low as 3 to 5%. I mean, you think about, these kids who are presenting to an emergency department in suicidal crisis, and we don't even ask about sort of the most lethal means of suicide that might be in their home. There's at least one paper that shows with electronic health record support screening can be improved. In one study, it was up to 80%. And we know QI interventions can actually improve screening. This is just one paper in pediatric residents where a QI intervention, wasn't the be all end all. It only increased screening to 34% from 3%. But when you start at 4%, I mean, there's a lot of room to grow. So we can impact this. Where I work at Seattle Children's, we instituted a very simple change in our electronic health record. Our EHR prompt initially just asked for access to weapons. And so we changed that to asking about access to firearms and asking specifically about how firearms are stored. And even just that simple change resulted in a pretty big increase in our identification of both firearm ownership and identification of unsafe storage practices. So once again, these QI interventions don't have to be particularly involved. We just tweak the electronic health record and we saw increased identification of firearm ownership. Next slide. So here's what we changed. We went from just asking about access to weapons and, oh no, my kid doesn't have access to weapons, move on, to actually asking about firearms. And in retrospect, as I was putting these slides together, I'd actually change the language on this. I think the word access is a little bit of a word that's not so great, because a family member still might say, my kid doesn't have access to firearms, they're locked up. So really being mindful of language of, I would actually change this, do you have firearms in your home or something similar? Because once again, we know from studies, people don't think kids know about the firearms or don't think they know the combination to the lockbox, and kids actually do. So we really have to sort of get over that barrier of, yeah, my kid doesn't know where it is, because they probably do. Next slide. As far as training both ourselves and staff and how to approach firearms, these are often difficult conversations. There are a lot of resources online that can provide training. Probably the best one, or the one I've been through at least, is CALM, Counseling on Access to Lethal Means. So it's an online, it's totally free, it just takes maybe an hour or two, and really gives you, I keep using firearm puns, I apologize. Really gives you strategies to approach families about their firearm ownage and storage practices. Some other resources, Harvard owns an online resource called Means Matter, which has a lot of good information about and strategies to counsel families and patients about firearms. And then finally, there's also the Bullet Points Project, which is a series of clinical tools for preventing firearm injury. Next slide. So once again, this is not a training in means restriction counseling around firearms, but I think it's helpful just to think about a couple strategies. So I think it's really important when you approach families about their firearms to be really respectful of the reasons they own their firearms. We don't all share the same lived experiences. We don't face a lot of the challenges some families do. We all inclusive come from different cultures and backgrounds and have different perceptions. So I think we need to be respectful of the decisions and respect the autonomy of owners making decisions about, we're going to help you and guide you, but we understand you're making decisions for the best interests of your family. It's super hard to work with kids in mental health crisis, but I think one of the little silver linings, or one of the benefits in approaching these conversations, is we all have a shared framework we can discuss firearms in. That you brought your child into the emergency department, or your child's in the emergency department because they're in suicidal crisis. Your child is at high risk of self-harm. So let's focus on your child and talk about, okay, how can we keep your child safe? This is not a conversation about firearms. This is a conversation about keeping your child safe. And maybe you do want to talk about medications and knives and other things first, and then approach firearms. And then, this really needs to be, when you talk about firearms, this really needs to be a collaborative process. Not, we may think, you may or may not think, that having the firearms removed from the home is the best strategy, but families may not be there yet. And firearm ownership and storage is not a binary. It's not everybody who has a firearm in the home is doing the wrong thing. Everybody gets the firearm out of the home is doing the right thing. You can, on the one hand, you can have people who have a loaded gun on their dresser, but there's a gradient of in between that. You can have a locked, unloaded firearm, hidden away that is improvement. So we can improve people's firearm storage practices, even if they don't do exactly what we would want them. We can improve safety in our patients and families. Next slide. I'm almost wrapping up. I was not watching the time, but so just really briefly, I think as we look at your care processes, means restriction counseling, specifically around firearms, should be a standard part of our care. And just so think about your processes. I know many of you are already doing this, There are ways it could be improved, or other approaches we could use. Next slide. Just a really brief plug. Our center at Seattle Children's a few years ago started a safe storage device provision program. So a family identified patient with a mental health complaint, family identified as owning a firearm, we offer free safe firearm storage devices. Cable locks, they're on the right, they're super cheap. They're less than $1. Most families aren't that interested in them. We found that most families are most interested in lock boxes. Now, the downside of lock boxes, you can't put a long gun in a lock box, but families tend to prefer them. And then we have trigger locks for families who do have long arms, who they want to secure their firearms. We've actually studied this, and we found that that providing devices and counseling improve firearm storage in our families versus usual care. And families are receptive to this. We've given away I have to update the slide. As of 2 years ago, essentially, we had given over 400 of these devices away. And so we continue I still see them out on counters, and it makes my heart feel good that we're still doing it. Next slide. All right, so just in summary, and I'm sorry I talked a lot. So just to summarize, kids who come in, even those we discharge for suicidality, are at a high risk of potentially completed suicide or repeat attempts. And so when we think about all the kids in our divergent part and who's high risk, these kids are kids we want to focus on. It's important to have some component of safety planning. You want to think about interventions you can do in your setting to improve access to care, especially with an equity lens. And then finally, think about your processes around use restriction counseling, and especially around firearms. So that's all I have. I'll pass it back over to Laura for a couple of reminders.
Thank you so much, Dr. Uspal, for this wonderful presentation. Thank you also to my other colleagues, Dr. Yanger, Dr. Remick, and Christina Madero for their support, and Luis Gonzalez as well. You can see the QR code for nursing hours right here. In a moment, you're going to see a poll launch. And then in the chat section, there's also the links that will take you to the same place where you can get your contact hours for nurses and your CEs for social workers and related professionals. The poll is now up on the screen, so please answer these 5 short questions. And we hope you have a wonderful day and that you continue to participate in the collaborative Fireside chats. Thank you so much.
Laura, I think there was a problem with the poll.
I can see that.
Okay.
Louis, if you think I should end the poll, or you should end the poll and restart, or if you see any other options, let us know. I also see some questions in the chat related to various resources, and now it's back. So there you go.
I'm gonna try to put some means restriction resources in the links. I'm just pulling them up. So.
Thank you. And if we don't get all of those handled, we will definitely provide them within the slides and in the accompanying bundle afterwards as well too. And thank you all of you for taking time to participate in today's session.